Well, welcome everybody. All 750 registrants to the webinar Locking Down or Opening Up, a debate on the best path through the pandemic, discussing the John Snow Memorandum and the Great Barrington Declaration. I'm Dan Polsky, Bloomberg Distinguished Professor of Health Policy and Economics at Johns Hopkins Bloomberg School of Public Health and Carey Business School, and the director of the Hopkins Business and Health Initiative, or HBHI. This is a new university initiative integrating research, practice, and policy to address the complex challenges facing the nation's health system. Through collaboration, multidisciplinary work, convening different perspectives, and breaking down silos, HBHI is an innovation hub to identify and facilitate solutions at the intersection of business, public health, healthcare delivery, and public policy. Our belief is that scientists are among our best when we work through complex issues constructively and collaboratively. Here at Hopkins and HBHI, we value intellectual exchange, and it is at its most valuable in the face of heated disagreement. This requires civility and open-mindedness. It is something we teach to our students and model through our own interactions and behaviors. The crisis of this pandemic has brought different groups to the table as never before as we seek the best path forward through unprecedented challenges. In that light, we launched the Johns Hopkins Interdisciplinary Zoom webinar series, Advancing Evidence-Based Decision-Making for COVID-19. This forum welcomes researchers from Hopkins and around the country in epidemiology, economics, statistics, ethics, system science, and beyond, as well as anyone seeking to learn more about emerging approaches to inform COVID-19 decision-making. In this context, we have tackled rationing, age targeting, evidence balancing transmission with social and economic costs, and the similarities and differences between epidemiology and economic approaches. Video for these webinars can be accessed at a website I'll put in the chat, where we will also put video of this webinar. So hopefully this sets the tone for our hour together: civility, open-mindedness, constructive conversation, critical thinking, and respect for legitimate differences. With that, I'll turn things over to our moderator who came up with this idea for the panel, Colleen Hanrahan. Colleen is an epidemiologist and infectious disease expert at Bloomberg School of Public Health. Colleen?
Thanks, Dan. And thanks everyone for attending, for submitting some great questions in advance, and for the questions I know you're going to be submitting during our chat, in our chat feature today. So I wanted to start just touching briefly on the state of the epidemic currently. This is our case count from today, daily case count. We just had 90,000 new cases of COVID yesterday in the US. There are new hotspots emerging in the Midwest and in the South. And across the globe, we are seeing also that we're, as a globe, kind of riding up what looks like another peak in the epidemic. And as a result, here I'm showing in France, they've recently had an increase. France and Germany have announced new restrictions as cases have surged. So this is where we're at today. Winter is coming. We appear to be headed into a new peak. And there's been a lot of opinions shared about the right approach in order to control this disease. So today we're highlighting two of these approaches. The first is the Great Barrington Declaration, which was put together and authored on October 4th by 3 career epidemiologists. The basic position from this declaration is that lockdowns to curtail COVID produce large and devastating effects on short and long-term public health. The statement advocates toward approach for herd immunity, where those who are younger are allowed to build immunity through natural infection, which then provides protection for those who are older and a much higher risk for mortality. The concept is called focused protection, and they advocate that life should largely return to normal for those who are not in the vulnerable groups, which includes returning to school, work, sports, business, and cultural activities. On the other side of this is the John Snow Memorandum. This was published in Lancet on October 14th by a large group of authors from throughout medicine and public health. And the statement holds that herd immunity approach is a dangerous fallacy, that there's not yet evidence of lasting immunity to SARS-CoV-2 infection, and that the approach would cause recurrent COVID epidemics. So the John Snow memo advocates for continuing restrictions to allow for suppressed transmission until public health efforts can effectively smother any local outbreaks. So in terms of our discussants and our panelists today, I'm going to introduce them briefly. And first, I'll just say that like most of us, almost all of us, none of them were thinking about novel coronaviruses until 2020. So our first panelist is Dr. Jay Bhattacharya. He's an MD, PhD. He's a professor of medicine at Stanford. And he's a health economist with broad research interests going from aging populations to health and medical spending. He's one of the 3 authors of the Great Barrington Declaration, and we're really happy to have him here today to contribute to this discussion. And so very appropriately, he'll be taking the side of Great Barrington Declaration in today's debate. Dr. David Dowdy is also an MD, PhD. He's an associate professor of epidemiology at Johns Hopkins School of Public Health. His primary research interest is in tuberculosis, and he works at the intersection of epidemiology, health economics, and infectious disease modeling. He has not signed either the Great Barrington Declaration nor the John Snow Memo, but today he is going to be defending John Snow Memo in the debate. And finally, Steph Baral is a physician epidemiologist, also at Johns Hopkins School of Public Health. His work focuses on HIV, epidemiology, prevention, and implementation, particularly within the context of human rights for men who have sex with men, transgender women, and female sex workers across the globe. He also has not signed either statement, but today he's offering us his position, which he terms resources before restrictions. So I'm going to be moderating the debate. We're going to start with 5 minutes for each side, starting with Dr. Bhattacharya. I'll be keeping time. And once each side has had a chance to present for 5 minutes, we'll go into 15 minutes of discussion. I'm going to be pulling questions from those that were submitted by email. We have a lot of great questions. So without further ado, let's jump into it. I'm going to stop sharing my screen here and hand it over to you, Dr. Bhattacharya.
Thank you, Colleen. So I want to start by just going through a couple of basic premises that underlie the Great Barrington Declaration. So the first premise is, and I think everyone on the panel will agree, that there is a very, very wide difference in the threat of the disease of infection for people who are older versus people who are younger. For people who are older, over 70, the evidence suggests that there's about a 95% survival rate, which is a very, very low survival rate for a disease like this. I mean, so an infection causes, it's a severe problem for older populations and also for people who have certain chronic conditions and so on. For younger populations under 70, it's much milder. So the seroprevalence data from around the world now suggests that the survival rate is something on the order of 99.95% from infection. So and that's just a basic fact I think everyone agrees with. The second basic fact premise is that that a zero COVID outcome is not possible. It's not in the feasible space. People point to places like New Zealand as counterexamples. But even New Zealand can't protect itself forever. We've seen outbreaks occur from outside. And I think if you look worldwide, as Colleen showed you the number of cases, I think it's at this point a fantasy to think about zero COVID as a reasonable potential outcome. And in any case, the amount of dislocation and damage to human civilization would be enormous to try to get there, because we try to get there and fail. Okay, so those are the two premises. The third premise, and this is something I want to correct Colleen on, is that that there's no such thing, given those first two premises, as a herd immunity strategy. Herd immunity is the end point of this epidemic, no matter what strategy we pick. It's not a policy to have herd immunity. The issue is and herd immunity is just a basic biological fact. It's like denying that the herd immunity will eventually be the endpoint of the epidemic is like denying that gravity exists. It will eventually happen. That's how the epidemic will end. So the only question at hand is, how do you get there safest? How do you get there with the least amount of human misery, death, and harm, with the greatest respect for human rights, for protection of civil liberties? How do you get there consistent with our values in a way that protects people? So the Great Barrington Declaration it's actually a call for a return to traditional public health principles. For one, acknowledge who actually is in danger and devote enormous creativity, resources, and energy to protect them. So just concretely, to give you some sense of who they are and how the current policy of lockdowns have failed them. So for instance, nursing homes. Much of the death through the United States and actually in many other developed countries has been in nursing home settings. We have failed to protect older people in nursing homes with this lockdown policy. The lockdown policy basically says if we control community transmission, we can control transmission in nursing homes, and that's evidently not true. We have asked older essential workers, the urban middle class, who are actually at risk from infection, high risk from infection, because they're essential and poor, we ask them still to go work and expose them to the virus because we haven't adopted focused protection ideas. At the same time, we've asked younger people who face very little risk from the virus itself to burden themselves with an enormous cost from this disease. We've closed schools, essentially depriving our children of their right to an education. We have, and with absolutely devastating effects that will last a generation. We have asked young people to basically cease normal activity. In fact, public health has has made such a mistake that what it's done is it's created a sense on people who don't face a huge risk from COVID itself. The risk of COVID is so high that people have stopped getting immunizations for their children. They've stopped going to get chemotherapy or cancer screening, with a mortality toll to come. In the United States, there's 100,000, there's 220,000 people that have died, 200 and counting, from COVID, but 300,000 plus, 320,000 plus excess deaths. Those extra excess deaths are lockdown deaths. So I think it's a policy, the current policy we have is an immoral one. We are asking people who don't bear a huge risk from disease to bear the burden of the disease, not in the form of COVID, but in the form of other harm and damage. So the Great Barrington Declaration says, let's respect the autonomy of them, let them go about their lives. And I'm not arguing against normal precautions that public health would normally argue. We're not arguing to go infect yourself. We're not arguing for COVID parties. What we're arguing is let people do the things that they value that are important, taking reasonable precautions. At the same time, devote enormous resources to protect the old. The results will be better both for the old and the COVID, in terms of COVID deaths, and also better in terms of non-COVID deaths and the respect of human rights. Thank you.
Great, thanks, Dr. Bhattacharya. Right at 5 minutes. So we'll throw it over to you, David. Go ahead.
Great. Thanks, Colleen. So I'm going to be defending the Jon Snow memo, but I should start by saying I'm actually not a huge fan of certain aspects of this memorandum. I do worry that in signing this document and having it's called the Jon Snow memo, right? That we're reading a bit of scientific orthodoxy, implicitly shaming. Implicitly shaming people who might have different perspectives. And I would not like to go about things in that way. I also feel like this memo doesn't necessarily provide a clear path forward. And again, that's something that I'm going to try and correct or at least address in this conversation. So where do I agree with what Jay has said? First of all, I agree 100% that the most important goal is to prevent misery, morbidity, mortality, and that zero is not possible, right? Secondly, I also fully agree that lockdowns are a harm to be avoided if at all possible. And the current policies as Jay was mentioning, have failed multiple populations. What do I disagree about? First of all, I don't think that it's feasible or right to label some people as vulnerable and others as not vulnerable. I think vulnerability is a spectrum and not really just based on age. So should we label our president as being vulnerable because he's 74 years old? What if you were 69? What if you were Black rather than white, right? And so I worry about a specific age cutoff, right? Are we really just talking about long-term care facilities? So like Jay suggests, 45% of all deaths, COVID deaths in the US have occurred in long-term care facilities or residents of long-term care facilities, but that leaves 125,000 confirmed deaths outside of those facilities. That's more than 3 times as many people who die in road traffic accidents in an average year. Nobody's arguing, I think, that we shouldn't be protecting residents of long-term care facilities, but once we start to expand the concept of vulnerability to age, I start to worry. Secondly, even if we could identify the vulnerable, the best way to protect those, I believe, is not just to isolate them, test them, and create an island, but rather to reduce transmission in the community. So I'll ask everyone here, would you rather live in a fully testing, isolated nursing home in North Dakota, where they've had 6,000 cases in the last week, or one with no testing at all in Taiwan, where they have 30 times the population and haven't had a single case in the past 200 days, right? So I think that reducing transmission in the community is the key to protecting the vulnerable. Everywhere you go, deaths in vulnerable populations track with the number of infections. And so the best way to reduce the number of deaths is to reduce the number of infections. Finally, even if we could identify and shield the vulnerable, people panic, right? COVID is scary to people in a way that the flu, for example, is not. And so let's just say I don't want to be the one looking for toilet paper in a place where the message is COVID cases in your city are doubling every week, but stay calm, we're protecting the people who are at greatest risk. I want to make a quick note on herd immunity. I agree 100% that herd immunity is not a strategy, it's an outcome, but we're not very close to that, right? So a very recent study just this week published in The Lancet estimated that about 9% of the US adult population is seropositive to SARS-CoV-2 as of January. So we have a really, really long way to go. Furthermore, the strongest correlate of seroprevalence was the cumulative COVID mortality rate. So, and again, wherever infection is occurring, people are dying. So how would I move forward? I would look to specific success stories. And I'll use the example of Australia that I think is somewhat similar to the US culturally. Australia is not more locked down than the US. Schools reopened for the most part in May. Daycare's never closed. Stadium in June had 30,000 people and was allowed. GDP projections for 2020 in Australia are a decline of 4.1%. In the US is 3.8%. So very similar in those regards. But despite these similarities, Australia's pandemic is 1/20th the size of the US, both in terms of seroprevalence, which is at 0.5% in July, and in terms of deaths. So the cumulative death rate per capita is also about 1/20th of that in the US. And so I'm going to say that there are 4 main differences between Australia's response and ours in the US, and these point the way to a strategy. First of all, knowing your epidemics. So for every confirmed case in Australia, they've performed 2,000 tests versus 13 here in the US. Second, targeting response not based on vulnerability, but based on where transmission is happening. So for example, when an outbreak occurred in Melbourne, they enacted restrictions not on a countrywide level, not on a statewide level, but at a level of 10 postal codes, right? So thinking where is infection occurring, and that's where we need to enact restrictions. Third, enforcing laws that people can tolerate. So in those 10 postal codes, for example, there were fines for not wearing a mask, fines for missing a curfew. I don't feel like masks and curfews are breaking the economy or breaking people in the same way that large lockdowns are. And then finally, supporting people who need it most. So Australia has passed legislation to support people who are caring for elders, people who are holding on to jobs, not just in a blanket fashion. So in summary, I think we agree on the goals. We agree that lockdowns are bad. We agree that zero is not achievable. But I would argue that rather than trying to shield, identify, shield, and protect the vulnerable, we should try to be reducing the level of infection by knowing our epidemic by testing, targeting our response to where transmission is happening, enforcing tolerable laws, and supporting those who need it the most.
Okay, thank you, David. And finally, we'll hear from Steph Baral. He's going to take us through his resources before restriction position on this, which,
Right.
yeah, go ahead, Steph.
Thanks, Colleen, and thanks for the invitation. I mean, I have to say, I think to sort of reinforce Dan's point at the beginning of this, the idea about being able to like openly talk about this is a major advance, because I think the moment we are afraid to speak as scientists about like evidence-based and rights-affirming interventions, we do a disservice, I think, collectively to the response, and surely we're not saving lives. So I think I just want to start with that. So I think similar to Jay, I'm going to start with like a couple premises, and those are like basic premises of public health. I think of public health as having sort of three core values. Those are equity, social justice, and participation. So equity is that we do more for people who need more. Social justice is that we try to balance intervention benefit and burden. And participation is that we engage the public and people that we ultimately want to use our interventions, that we don't single-handedly as public health come up with things and then just push them on people. I just want to say as a personal anecdote about Australia. So my grandmother was like a refugee to Australia from Poland. I think of it as like a place that saved my family in many ways. And she moved to Melbourne, where she lived and died, many years ago. But what happened in Australia was this specific lockdown, particularly recent immigrants that were only at risk in many of the same ways that we've seen in so many other settings, whether it be New Zealand, where it was 90% Maori people, whether it be across the United States, where we've just seen these deep and seething inequities that are, even in a place like Australia and even in a place like Canada that we like to think was more equitable, have been sort of the defining characteristic of this infection, that it has undermined and shown us all of the inequities that exist, including in Stockholm. And so I just sort of want to start with that. I think when I think about interventions to date, I don't recognize a single empiric intervention to date. Like, I don't even think that I don't think social distancing are empiric interventions, because they don't react to like individual or network level needs. And so they are what they are. They're interventions. I just don't think of them as empiric interventions. Similarly, and I don't know if like the lightning is going to strike, I similarly don't think of like masks as empiric interventions. I recognize that they're just like something that we feel like we can do as a mandate and just kind of hope, that it's going to work. But ultimately, it represents a passive strategy that's ultimately implemented by the police and by sort of collective blame and shame, and not necessarily because it's like an empiric intervention oriented, or I should say evidence-based intervention. I think the fundamental problem that I've seen within COVID is that we wanted individual people to take on what should be social costs. And so we want people who are generally well, right, who get tested, to isolate, to quarantine and to isolate. You quarantine when they're under investigation, isolate when they're positive, if they're positive. But we're not providing them the means in order to do that. So we're asking people normally already on the economic margins to absorb social costs. And that disconnect between social costs and personal benefits doesn't feel like a sustainable strategy to me. I think there's a couple things that we should absolutely be doing. So I say this like I'm calling in from like a homeless shelter where I work. I'm not in for effect, it's just in clinic. Like, what have we done for the venues and the settings that are so disproportionately affected in the context of doing shutdowns? Like, should we be shutting down the area that is around this homeless shelter because we're at such disproportionate risk related to the fact that we're in a shelter and that it's just a congregate living setting? Or should we start thinking about like, what are the programs that we need to put in place to actually break those chains of transmission? As I think has been happening at individual venues and centers, but it hasn't really been taken to scale. I think there's a couple core things that we need to be doing. So one is, it's amazing to me that this far along, we are not providing paid leave, particularly for workers in long-term care facilities and in shelters that are like agency hires, contract hires, and this is kind of universal. It's amazing to me. It's like a fundamental failure that we haven't done that, when it is like a major source of thinking about how you're going to prevent virus from ever entering the building. Because I think once virus has entered a site, then it's like testing and PPE and all those sorts of things, and masks, obviously. But once virus has entered the site, it's like hope is your best strategy, as compared to really trying to think about how you're going to prevent that. Housing support. Often when we're testing folks, telling them to isolate, I think the natural question is like, where would you like me to isolate? You know, and we set up programs in my own city for folks within the homeless system, but not for folks who were densely housed, who are couch surfing, unstably housed, et cetera. So I think this question about like, where would you like me to do that? And particularly for people in multi-generational households, telling them to isolate without providing them the means to do that feels like a disconnect that is just going to propagate transmission. And then finally, I'll just say this idea that people have a tremendous amount of barriers to testing that are often, you know, designed for wealthier folks who can work from home, might even be able to do like a conference call while waiting in line to get tested. Obviously not feasible for shift workers and others who are, as we know, disproportionately affected by COVID. So we've misaligned the programs in general from where the needs are. So I would say, like, indeed, Colleen said, like, I have this little thing about resources before restrictions, but it's only because it feels like a very natural public health strategy that we try and address unmet needs with resources. And if people have higher unmet needs, we address those with higher and more resources. And if all of that fails, fine, let's close our societies. But that should be something that we do when everything else has failed. I'll finish by saying that I think the precautionary principle has been like, it's been another, I don't know if it's a casualty of 2020, but it feels like it is used often. And people just talk about it, well, we need to close down Halloween because who knows? Or we need to close down restaurants because who knows? And I think we need to do a few things. One, we need to think about the precautionary principles as not just like what are the potential benefits from intervening, but also what are the potential harms? And both of those should be along a continuum of probability. And secondly, like we have to get back to a time of empiricism. If we're going to close restaurants, it should be because we've identified clusters that are at a significant scale and make up a significant proportion of the epidemic in terms of attributable fraction, both in terms of immediate as well as downstream infections. Fine, let's intervene there and let's think about how to address that. But I think we have to move away from this approach where the first time cases are, as cases are going up, we've made it easy for governments. It's like, what do we close now? Okay, let's close strip clubs. Let's close restaurants. Let's close, you know, what we say in public health is like people just chasing unicorns and doing pandemic theater of just like closing something just to show action. So I'll finish with that. I think that like there's been a, you know, I worry about a future where every time a pandemic arises, because like this isn't our last pandemic. We might have another pandemic in the next 2 to 3 years. Like that is just the nature of our world at this point, where we move to these sort of grave, close down the world restrictions, nationalistic, close our borders, et cetera. As compared to, by the way, that wasn't universal across Sub-Saharan Africa and Asia. There's been a lot more country to country coordination, but Europe and North America, like we've just closed down in a very nationalistic way. So I'll stop with that. I worry about this future. And I think we need to get back to a point when public health can function independently, do what it needs to do to try to mitigate the epidemic and save lives. So, thanks.
Hey, thanks, Steph, and thank you everyone for illustrating your thoughts further. I think one thing people have been looking for are more details, more of the ideas behind these statements, identifying more of the action points as we go forward. So I want to start with a question for Jay, which gets to this the older population that the Great Barrington Declaration and your sort of position would like to, I think, well, everyone would like to protect. My question is, what's gone wrong so far? This certainly seems like a situation where we kind of quickly realized who was at greatest risk. we know where they were, we were unable to protect them. So what are some of the strategies that we can use to keep them safe while allowing for natural infection to occur among people who are going to have much less morbidity and mortality?
Thanks, Colleen. So actually, let me just start by a point of agreement with David. I completely agree that the vulnerable is more than just the old. I mean, there's evidence that if you have diabetes, for instance, and other conditions, so it should be a multifaceted consideration of who's vulnerable. Colleen, so the question you have is how do we protect the vulnerable? It depends on where they live and who sort of what their situation is. So for instance, I've already talked about nursing homes, so I'm not going to beat that dead horse, and I've talked about older workers. I completely agree with Steph's call to use resources to protect them, which we haven't done, and it's shocking to me as well. Let me talk about another one that I've sometimes heard, and I didn't get the chance in my first 5 minutes, is about multi-generational homes, older people living mixed in with younger people. So first, let me just note, the lockdowns have created multi-generational homes. They have the economic dislocations of the lockdowns have led many, many young people to go live with their older parents that they otherwise wouldn't live with. We sent university students home to live with their older parents. We in part intensified this problem with the lockdowns. So I think that's one. Ending the lockdowns, I think, would help address that. Second, I think there are like creative ideas possible. And again, I'm shocked that we haven't done this. For instance, we've used hotels to house homeless people, which is, I think a good idea. Especially since hotels have been empty. We can do the same when community transmission is high for older people living in multi-generational homes. We can offer them access to temporary living facilities, voluntary if you want. If a teenager in your household and your grandma, a teenager in your household is exposed or sick or engaging in normal teenage behavior, and you're worried, we offer local communities offer the ability for those folks to live temporarily in a place outside, like a hotel room or whatnot. I think those kinds of ideas are certainly possible. We can encourage people to go live, older people to go live with with relatives, brothers and sisters nearby, and other kinds of ideas like this, depending on what's possible and within the community. It's definitely possible to protect older people living in those multi-generational communities. I think this is a complicated question. The entirety of public health should be devoted to answering your question, Colleen, not just me. It's actually, I'm actually been dismayed by the lack of creativity by public health. I think partly because we think that if we just control community spread, we've solved the problem, and evidently we have not. There's still people that need to be protected, even if community spread were to be controlled.
Thanks, Jay. And David, I just want to throw it over to you to see if you have anything to add.
No, I mean, I think that in general, the three of us are in rough agreement that what we need are creative and focused solutions to protect the people who are at greatest risk. I do think that it is important to be responsive, though, to the overall level of infection in a community, right? I think that where infection levels are higher, we need to be more proactive in our response. And by proactive, I don't mean locking down. I mean along the lines of what Steph is suggesting, providing more support, allowing people, enabling them to act in the ways that they need to protect themselves and to protect their families. Also being proactive about testing and seeing where transmission is occurring on not just, again, kind of a country or state level scale, but really down to locales. And this may be a controversial point, but I do feel that focused and temporary restrictions in areas where transmission is intense can be effective and can reduce both inequities and long-term morbidity, mortality, misery at a population level. I think that we've seen, like, for example, again, if we're going back to the example of Australia, First Nations people in Australia have 1/4 the risk of dying of COVID as the average individual, whereas in the United States, American Indians, Native Americans, Alaska Natives have 5 times higher risk of hospitalization due to COVID. And so by keeping transmission at a lower level and being focused for temporary short periods of time, I think that we can actually improve equality and make things more tolerable for the population.
Thanks, David. We got a number of questions about the country of Sweden. Some questions holding up Sweden as an example that the US should follow, some dismissing Sweden as an anomaly. I see Steph has already unmuted. Steph has, well, you're Swedish
Swedish,
but as guilty as charged. So Steph, I thought you would be the right person to sort of talk about this. How should we think about what happened in Sweden?
Yeah, I mean, so it's true. It's guilty, absolutely. So I mean, just I don't know if one needs disclosure these days, but I grew up in Sweden. My mom lives in Sweden, and so I have a vested interest in how Sweden does, just like anybody else. In fact, I speaking to my mom today or earlier today. I'll say this as a starting point. Like, there's nowhere else I would have wanted my mom to be other than Sweden for like the last 8 months. So, I mean, I don't know what that says to anybody in the audience, other than to say I love my mom and I feel like she's been very safe in Sweden. I think that I don't know that like the Swedes ever thought that they were going to become some sort of flashpoint. I think for right-wing Americans, so the last time Sweden was a flashpoint was like no-go zones on Fox News, as many of you will remember. Like half of Stockholm is burning and nobody can go there. So I don't think like Sweden sees itself as like a political pawn in some sort of weird, obviously, campaign process that's gone on in America over the last, I don't know, 4 years. And so I think that, so I'll just say that aside, like what happened in Sweden is absolutely like specific to Sweden. Any country, like I worry gravely about like, let's look at case counts even in Australia, let's look at in New Zealand, anywhere, like it's like there's so much contextual dynamics and so much heterogeneity that I think there's a little bit of a challenge in terms of like really drawing inferences across places. But I will say that like there's no doubt there was a tremendous amount of mortality in Sweden within long-term care facilities. That was a failure. Anybody who doesn't recognize that as a failure is not paying attention to what's happening. I think that there has been, they focused more on an empowerment strategy and an education-based strategy than a restrictions-based. Everybody's like, oh, Sweden had a lockdown. I'm like, yeah, Sweden had a lockdown in the sense that they asked their citizens to go out less. And they did. They did go out less, the ones that could. And the ones where there was more mortality was the same dynamic of inequities that we've seen in other places. People who are recent immigrants to Sweden, people who lived in multi-generational homes, especially for those over 70 who lived with a working age person, were at much higher risk of mortality, reflective of underlying mortality, by the way, and something that's like a deeper inequity. So I would say that like, but we also have to keep in mind that like Sweden instituted paid leave from day one, very early in this thing. As much as like this recent Time article, which is like, I think a disaster. I mean, I think it's so easy to like, we know this, we're all statisticians or epidemiologists, we can cut data to tell any story we want. So the reality has been that, sure, Sweden has had low mortality since the end of June. It's been pretty sustained, although there's increasing amounts of ICU admissions that are ongoing right now. So that's not, and I think Tegnell was on the news this morning asking citizens to be vigilant, to do what they can to protect themselves and protect their families as he should. And I think we need to learn from that in terms of the empowerment-based approaches that they use. And I think we similarly need to learn from the failures where there's been grave mortality related to underlying inequities. So, I would say this, that the idea that like Sweden chose its economy, they're like a bunch of socialists. The idea that we would like on some sort of political spectrum of America, they're so left that they don't even fit on the same line. So I think there was no choice of the economy over the health of its citizens. I don't know him, obviously I don't know him personally, but this was an independent public health agency doing public health, following public health principles. And so, I think that to me is a much more sustainable strategy over the long term than I think what we've implemented here, which is just like, I don't know what the exit strategy is. I don't know how we exit out of these things without, I don't even know what that looks like. And I think they have a much kind of more sustainable where they can increase or decrease their approaches in terms of intervention intensity in an easier way than many other places in the world. Thanks.
Thanks, Steph. Sort of going along with those, the theme of the economy, also resiliency and sustainability of response. I want to direct a question to you, Jay, particularly because of your experience as an economist. The collateral effects of the COVID lockdowns and restrictions, although we all kind of have some anecdotal sense of them, we're looking at the economy, the unemployment rate, the collateral, some of the collateral effects are really difficult to directly measure. In my field in TB control, we're only just starting to understand the tremendous effect that lockdowns have had on TB control globally, here in the US and then in countries where TB is a huge problem. Multiply that by mental health, chronic disease, poverty, food security. All of these are very fuzzy numbers. Do you think the public has a sense of how can we really balance the deaths, the morbidity, mortality that we see from COVID? How can we balance that against all these collateral effects that we're coming up against, but which are harder to get your arms around from some of the restrictions and lockdowns to COVID?
And Colleen, that's a daunting question to me as a health economist. I study, and Dan knows, we study health economics. We study the kinds of costs and it takes a long time, but I can to figure out to actually establish them. But the collateral harms from the lockdowns are so catastrophic that it's gonna be the work of a decade of health economics work to actually start to get a grasp of it. I can just maybe give you a sense of this from a single number, which I saw, I think sometime in April from a report in the UN. And what they did is they looked to see, okay, there's going to be X% economic harm. So the GDP of the world will go down by 6% or 7% or whatever it turns out to be from the lockdowns. This was in April. And then what they did is they just did a distributional thing, said, okay, how many people live at $2 a day? Well, that's what you need to be able to eat, not starve. How many additional people will there be living at below $2 a day as a consequence of this economic collapse? And what they estimate is that it'll be 130 million additional people who will starve this year as a consequence of the economic collapse caused by the lockdown. That should haunt our conscience whenever we're thinking about the lockdown. Now, it's not all lockdown. I mean, just to be fair, and this is something that as an economist you want to take seriously. I think there would have been economic damage even if we had adopted a worldwide approach more like Sweden than we did. But there's no question that the lockdown contributed to a substantial number. Let's say even 10%. Well, we're talking 13 million extra people that would be alive, not starved, but for the lockdowns. We have to consider those people as well. They count in the calculus and they should belong in our calculus as much as the deaths that we see from COVID every day. The public sees the very, very saliently the deaths from COVID because it's blared in front of everybody. But the deaths and the harm done to every poor person on every poor country on the face of the earth should be as salient when we're thinking about the policy.
Thanks, Jay. David, I want to turn to you. I know you've done a lot of work with diagnostics and diagnostic testing. And we had a lot of questions around diagnostic testing. What can you tell us about where you think when to test, who to test, where to put the cutoff on what a positive is? How would testing factor into kind of what you see as the optimal approach going forward?
Well, so without getting into too many of the nitty-gritty details of who to test, where to test, I think the key is you want to use testing in such a way as you know where to respond, right? And so if we see positivity levels going up in a community, for example, that's where we should be pouring in more resources to do additional testing so that we can figure out where transmission is occurring and how, I mean, again, I think as both Jay and Steph have been arguing, how we can be creative about responding to that, right? So if I know that transmission is occurring in one particular venue, right? Finding a way like to support the people who are engaged with that venue, making it such that they don't have to continue to interact with each other, and get them through that, right? And so, and there should be more and more testing, and that helps to define the exit strategy too, because then you know when transmission has declined as well. And so again, I don't want to spend too much time on a response about the details of diagnostic testing, but just to say that we should be using it to figure out where transmission is occurring, where cases are cropping up, and therefore how to focus our response. Without knowing that, it's really difficult to come up with targeted or creative responses for reducing transmission, and by transmission also morbidity, mortality, panic, the possibility of lockdowns, etc.
Thanks, David. Any different opinions, Jay or Steph? Anything to add?
Yeah. Jay, go ahead.
Oh, sorry, Steph. You can. Let me just, because I took a pretty strong position about testing earlier. So let me just. I mean, I think again, let me agree and disagree with David. I do think the testing to track how community spread is useful, but we should do it in a representative way. Right now, the testing regimen identifies cases not randomly. It depends on who shows up, whether you test asymptomatic people or not. It doesn't actually give an accurate picture of community spread. The second thing I'd say about testing is that we can tune the test to be very sensitive or very specific. There's a trade-off there, even for the PCR test. A very sensitive test used in schools to identify cases that most likely aren't transmissible, and where you use it to close the school down is a terrible use of a test. We should think about the error properties of testing and the use to which the test is being used when we're thinking about testing, not simply just test in order to identify cases. So I think that we've sort of failed at that as well. We conveyed to the public this idea. We put up the cases numbers at the beginning. Who's infected? Is it older people? Is it young people? That matters a lot more than just the total number. I mean, I think you want to use tests to protect people, to save lives. You can use it in to guide medical therapy, obviously, but you should think very carefully about how these tests are being used and the harms that. So the dictum that more information is always better is actually not true here. If you use the more information in a way that harms people, then I don't want that information. So I mean, I think in theory, one could imagine a world where more information is better, but that's not the world we live in right now. Those tests are being used to close down schools, to quarantine people, with I don't think only sort of an indifferent link to actually controlling the harm from the epidemic.
Yeah, I mean, I think it's important to. I just want to jump in here. So I think of testing for sort of two reasons. Like one is for like epi purposes, and I think I totally agree with Jay. I mean, like I love data. Like we've started figuring out how to deal with these collider biases and et cetera, about like, some of the selection biases that exist in terms of how to test to start inferring what's happening and trends, et cetera. I think we're getting better at that, although that's still a work in progress. But testing as a prevention strategy, like I feel very strongly like test or a diagnosis is not a prevention strategy. It has to be linked. For some folks, like again, I think it's indicative of like how this whole response just feels really well aligned for like rich folk. Sure, if you're rich and you get a positive test and like go into your home where you likely have at least one room per person in your household and isolate, get food delivered to your home, do all of what you need to do, and then you're fine. If you're lower income and you get you asking people to like test, that's not an intervention. That the intervention would be making sure that they don't, if they're well enough that they're not in the ICU, basically you're then asking them to isolate, to quarantine and isolate. And I think the fair question has to be, how are you making sure that that's feasible for them? What resources are you providing them to safely quarantine and isolate from all of the various high-risk people, either in their occupation or in their household setting? And if you're not doing that, then the test is not an intervention. it's just like a piece of data, and people like me love data anyway. So I think from a data perspective and writing papers, it's one thing. From a prevention perspective, I think we should have a very different kind of understanding of the utility of these tests.
Can I chime in with a question from the chat? So there's a lot, and we encourage it, and we apologize for not getting to the 500 questions in the chat, but I just want to, not getting to all of them right away. This is from Daniel Morgan. How do we get to a more middle of the road approach? It seems like there will be some failure with any path, and we need to balance harm. So, we've kind of set this up as a debate on two sides, but I see so much agreement, and I don't know if we're all going to agree on a middle of the road approach, but maybe from what we've learned in this exchange, are there any kind of concrete ideas for things we could do going forward that maybe we haven't already said? So how this conversation can kind of advance the discussion. Jay, do you want to start?
I mean, obviously, I'm a partisan on this, so I have to defend my position. But I wanted to come in this conversation wanting to learn, and I think I have some from both David and Steph. So I do appreciate that. At first, I think we have to talk to each other. I think this like tendency toward trying to suppress the opposite view, or well, actually suppress basically one-sided view. We've seen basically. I mean, we put the Great Barrington Declaration out, and Google immediately shadow banned it. I mean, it's absolutely shocking to me that scientists cannot speak to one another over disagreements over fundamental things. We have to have an open discussion, and this attempt to sort of suppress people you disagree with has to stop. We can't. So I don't think a balanced view is possible unless we have discussions. And Dan, I have to say, when you invited me, and Colleen, when you invited me to this, I was very, very pleased. I mean, just over the moon ecstatic, because I wanted to learn from people that don't disagree with me. I mean, absolutely, that's the only way forward in science. So, okay, now let me do the partisan thing. I think focused protection is the balanced thing. We have to account for the harms that we're imposing with lockdowns on people. We shouldn't ask people who don't bear a huge burden of COVID to bear huge burdens from lockdown harms. It's not right. At the same time, we have to acknowledge that COVID is a deadly disease, and there are groups that are at risk from it. We have to do our absolute best to protect them if we can. This is not possible to get to a utopian world where we have zero COVID and we're back in 2019 again. It's just a question of minimizing human misery, minimizing death. It's going to require us to acknowledge that, stop blaming each other, listen to one another.
Yeah, I think you're muted, Dan, but I'll jump in. I mean, first of all, just to say, Jay, I really appreciate you being here, Steph, as well. Like, I've learned a lot from this discussion as well, and I think that the only way for us to find out where we agree on things and where it might be a reasonable middle road is to have these sorts of discussions where we bring in people who might have different perspectives but are willing to talk, and hopefully in a respectful fashion. And so just to give my own thanks to my co-panelists in that regard, because I feel like this has been a great experience for me. I also agree with Jay that we need to be thinking about how to be focused in our protection. I think we need to do it in such a way that is not necessarily a one-size-fits-all strategy. I think that when we have even a one-size-fits-all focused protection strategy, that runs the risk of creating more inequity than it solves, creating sometimes even more human misery than it solves. And so I really do think that this has to be something that is done on a local level or on a small level where people understand the context into which each of these interventions that we might be employing, that they understand what that context is. Understanding what the history of transmission has been in that community, and figuring out how we can reduce transmission, particularly transmission among those who are at greatest risk of suffering the worst outcomes. And so without that sort of customized local approach, I think, like, again, one size fits all approaches are bound to fail.
Yeah, I mean, maybe so if I can have, I mean, I alluded to this earlier. I have to say that like I worry pretty gravely, and I've actually had this happen to me personally. Like I think the first time in my career, I was actually like afraid to speak, which is crazy. And I think is crazy because I have all the like I have a lot of these sorts of elements of privilege, and I felt a personal and professional fear that I think is is inappropriate. Never mind, I know a lot of folks that are more junior and further like earlier in their careers are feeling in very real ways, and it's hindering conversation. And I think like we just have to overcome this. The idea of likening the uncertainty around this brand new virus in this new dynamic to like whether the earth is round and whether we orbit around the sun does such a disjustice to a lot of the uncertainty. And I think many of us are used to managing uncertainty, but I think this idea of pretending that there isn't uncertainty does a disjustice to science and the fact that science is a process, not a destination, and surely not a popularity contest. And so I think, so in that, I'll say, I mean, I've laid out, I think, very sort of traditional public health principles. I continue to believe, as David said, if you get back to a process of like local public health being able to manage, resourced from the feds, resourced by the states and the provinces and the national governments to do local public health, you're in a much better position. This idea of federal mandates, restriction-based approaches is going to harm the relationship between public health and the public for decades to come. I even worry about people that don't want to apply to be like MPHs anymore. Like they just look at what is public health, like is it the police or is it really like this empowering, oriented approach to solving the world's problems? So I will just say that I worry about a future where it's like this is what public health has become, and it's surely not the public health I trained in. And I should note, public health is all my training. It's all I've ever trained in, and this all feels very foreign to me. So thanks.
Well, I think we're at the hour. So with that, I want to thank Colleen for terrific moderating and for coming up with the idea to bring all of this group together and this idea of this debate. And thank you to our panelists, David, Jay, and Steph. Really extraordinary discussion, and just delightful to see such a productive exchange. Thank you to Jamie for organizing it and for increasing our capacity so we could handle our audience. And I think most of all, thank you to everyone who spent their time with us today, listening and providing comments and discussion and engaging with us. And just a brief apology for the inability to really exchange with the chat, but we'll have a chance to look at what everybody sent. And so thank you to all of you as well. And I hope you have a wonderful weekend, wonderful Halloween weekend. So bye-bye, everybody. Thank you.
Yeah.
Thanks, everyone.
Thank you. Okay.